Okay, thanks to the operators for the first live case. Fantastic result there. So the next speaker is Dr. Fraser from the Manchester Heart Centre. Another member of the UK contingent, also did some of his training in Amsterdam at the OLVG. And Doug is going to tell us about the rationale and data behind downsizing and why we should aim to do it.
Thanks very much, Jim, and thanks very much, everyone. I worked at the OLVG in 2001, 2002, and 5 French was the default access at that time, which shows that Ferdinand, with the other colleagues in the OLVG, have been real pioneers in slender techniques for really quite some time. So I'm going to be discussing primarily the issue of radial artery size and what the rationale is for downsizing in radial access. So the question has to be asked, why should we try to downsize? 6 French, which is the most common catheter size and sheath size, is appropriate for a very wide range of interventions, covers almost everything that we can do nowadays, and in general appears to be relatively well tolerated. What are we talking about in terms of slender techniques? Are we talking simply about elegance and about the way things look, or are we talking about different things? Well, of course, we're talking about outcomes for patients, and so I'll be going through some of the reasons why I think we need to do better than 6 French conventional. So Ferdinand has introduced some of these concepts. So the potential advantages of using smaller catheters are that when we use smaller catheters, we use less contrast, we're less likely to get bleeding problems, we can achieve hemostasis quicker, so our turnaround times are quicker. There should be less discomfort for our patients, and I'll show some evidence for that. And importantly, and what I'm going to concentrate on, is that slender techniques traumatize the radial artery less than our conventional techniques. So there's a wide variation in radial artery size. That's the first point that we have to understand. And that for those patients with small radial arteries, radial 6 French sheath at 2.6, 2.7 millimeters is significantly larger than the radial artery lumen. And it's still significantly larger than the radial artery lumen after vasodilators. So I've pulled out a lot of studies here looking at what the radial artery size is, and these are from different regions around the world. But you can see that the mean radial artery size is somewhere in the region of 2.5 millimeters. And we're using 2.7 millimeter catheters in almost all our patients if we're 6 French operators. And even when we go down to 5 French sheaths, where we're getting down to 2.4, 2.5 millimeters, we're still larger than the radial artery lumen in almost half of cases. So that's the main justification for using slender techniques. So this is variation in radial artery size that we measured in our centre. And just to put this in colours, these patients here had radial arteries smaller than a 5 French sheath. And then these patients here, most of the patients, had radial artery size less than a 6 French sheath. So we're inserting a sheath that's larger than the radial artery lumen. And as I say, that's been reproduced in many publications. This is another publication showing exactly the same thing. So what happens when we put a sheath that's larger than the radial artery lumen? Well, we do a lot to, in our centre certainly, give our patients sedation and make them feel comfortable. But there's no doubt that when we insert a radial artery sheath that's larger than the lumen, we're causing trauma and we're causing pain to that radial artery. You can see here that when we do that, when we're using a sheath that's larger than the radial artery lumen, we even have persistent pain after 24 hours. So we're causing sustained damage to the radial artery that's causing persistent pain, not only at the time of the procedure, but even 24 hours later. This was an early study from Dr. Saito showing that radial occlusion was higher if we use a sheath larger than the radial artery lumen. And then there's been a number of studies showing that there's significant trauma to the radial artery when we're using our radial interventions. So here we can see that 44% of radial arteries in this study that mainly used 6 French sheaths had evidence of dissection, and a quarter had really extensive damage to the radial artery. And this translates into neointima formation and narrowing of the radial artery in the longer term. This has been shown by other different techniques. So this is an old ultrasound study showing several years ago that the incidence of diffuse stenosis was 22% following radial intervention. And when we take out radial arteries and use them for grafting purposes, you can see here that following radial catheterization, 3/4 of radial arteries had significant intimal proliferation. And that translates in our practice into the fact that the more radial procedures we do on a radial artery, the smaller chance we have of succeeding, because we're causing ongoing occlusions, more and more occlusions the more cases we do, and more stenosis. And I think that non-occlusive injury is something that's been under-investigated. That's been repeated recently by Olivier Bertrand. When we think about our practice, we can easily be getting into this zone where 30 to 40% chance of the radial being occluded after the patient's had an angiogram and perhaps 2 PCIs. So we've started by saying that there is a variation in radial artery size, and does that correlate to occlusion? Well, this is our data, and this is Yokoyama's data, which really suggests that is the case. It's these very small radial arteries that are occluding, when actually we're putting a 6 French sheath that's much larger than the radial artery lumen. It's causing extensive trauma, and it's those radial arteries that are occluding. Does 5 French make a difference? Well, I'm sure 5 French does make a difference. These are the 2 published studies that show reduced radial occlusion rate with 5 French. But one of the issues here is that the occlusion rate in this study from Leipzig was actually higher in 5 French than it was in 6 French in the other study. So I don't think that we've yet got a very good data showing that downsizing reduces radial occlusion, but we'll come on to that and deal with that much more extensively later on. This is some of our data comparing a sheathless approach, which was essentially involved a 5 French sheath, so it was a 5 French approach, comparing that with 6 French. And we didn't get as much a reduction in radial occlusion as we hoped. And I think I would try to persuade you that that's because even 5 French systems are still too big when we're getting the occlusion of here in the 5 French cohort, when we're getting occlusion of these radial arteries that are still a lot smaller than our 5 French systems. So we're actually causing a lot more trauma than we think with 6 French, and I'm sure 5 French is better, but perhaps not good enough. And that's why I'm very pleased that Ferdinand and colleagues are arranging this meeting so that newer techniques to reduce things further can be investigated. I would try to say that radial occlusion is the tip of the iceberg, and there's a lot of non-occlusive injury that's occurring that we need to be thinking about and we need to be investigating. So what can we do about it? Well, we've just seen a great example of using the glide sheath slender, and you can see here that the outer diameter here, it's a 6 French sheath, is actually a smaller outer diameter than some 5 French sheaths. So this is doing a lot of work for us, and this is an excellent product, and we use this in all our 6 French cases, the glide sheath slender. And this is being examined by an international randomized trial to look at outcomes comparing it with standard 5 French by colleagues in this room. So where are we now? I think the glide sheath slender, I think it is an excellent solution to 6 French. It reduces our sheath size to essentially 5 French. And then if we want to go smaller than that, then we'll see a lot of these other techniques over the next few days. But I would say that there are difficulties with these techniques, and that what we really need is industry and individuals to be very interested and involved in this issue, to progress the field further. So I'll just show some of the publications for these techniques. This is 4 French angioplasty. This is a sheathless angioplasty with a 6.5 French, which 6.5 French is equivalent to a 4.5 French sheath. This is a different sheathless system from Medikit, so they have a 6.5 French, which has a larger inner lumen than the Asahi system. And then there's the Medikit 5 French system, which is virtual, which is same outer diameter as a 3 French sheath. And then, impressively, there's significant use of this 1 French, virtual 1 French system, which is a 3 French catheter, so equivalent to a 1 French sheath for diagnostic procedures. So there has a lot of work that's been done, but still I don't think we have full solutions to the answers of reducing radial injury. And so where should we aim? And this is my personal view. I think that for intervention we really have to try to aim to 2 millimeters or less for our sheath or catheter size. For angiography, perhaps we could aim lower than that. To aim for 2 millimeters for our interventional systems, then we either have to be using very, very low diameter sheaths, or we have to be using sheathless techniques. So I don't think that we're quite there yet in terms of the technology. It is important to reduce radial trauma, but maintain convenience and safety of the procedure in terms of the coronary outcomes. I think that the glide sheath slender is really a very significant advance to doing 6 French angioplasty. 5 French has been used as for more simple angioplasty for many years, but still has the issue of no good solution for thrombectomy, and in Europe no good solution to kissing balloon. And I think that there is definitely a rationale for working to smaller systems. Perhaps there's also a rationale, as I say, because of the variation in radial size, to be doing pre-procedure imaging and matching our equipment size to the radial artery lumen. And certainly there's a need for further studies to prove benefits of new systems, in particular in relation to radial artery trauma and radial artery occlusion. Thanks very much.
Just a comment for you. Just listening to your lecture, I was realizing that we need simplification about all this definition of diameter, etc. You cannot continue to speak about virtual 1 French according to 3 French. It's a nightmare to, as expert, even sometimes we are lost. So we need, and maybe the Slender Club is a good group to think about the new definition. 1st generation catheter, 2nd generation, and to have simplification about the diameter of the sheath and the catheter, and to have this type of, because you cannot have such a lecture in a traditional interventional group. They cannot follow.
I totally agree with you. I think that definitely we need a simpler system in terms of calling what we're doing, and also there is a huge misunderstanding in terms of what a 6 French sheath means. People don't realise that that we're talking about the inner diameter rather than the outer diameter, whereas with a catheter we're talking about the outer diameter rather than the inner diameter. So there's an awful lot of confusion out there, and I think that yes, we need to simplify it and make it clear. Absolutely.
Also a comment, I think we have to remember that we are working on coronary disease, and this is where is the danger. Of course, there is some problem with a bigger sheath. You can damage a vessel, maybe occlude it. But I think you have to look at the internal lumen you use to treat the coronary lesion. And you said just 2 minutes ago that in Europe we cannot do a kissing.
Yeah.
So kissing is something to see with the bifurcation. We may have some alternative solutions. But imagine today you cannot put a covered stent. in slender catheters. Of course, this problem of the problem of rupture of perforation is occurring quite rarely, but we are not dealing in a mass. We are not doing a mass job. We are involved in each of the procedure, and the day you will have a perforation, you have to bring a solution to the patient. So I think we are speaking about something virtual. This is something that has to see with a few centimeters in the radial artery. But you have to remember that the most important is what you are doing in the coronary arteries. And I will say probably that also during the live demonstration. What will occur if you have a perforation or rupture?
No, I mean, I totally agree. I mean, I think that, you know, there is a good reason in terms of the radial artery to do slender techniques, but we do need better technology in order to be able to do those slender techniques safely for the coronary intervention, and the coronary results must come first.
Yeah, and I have to add to your presentation that it's possible to perform rotablator with 175 in 6 French.
Yeah,
I did it many times.
Just last question from Giovanni.
It's not a question, it's a comment. There are available 5 French compatible cover stents, so that the products are moving that way. So I don't think we have to be afraid. Of course, we have to take in consideration what we have and compatibility with the guarantee. But there are 5.
What is a company? Is it you have to implant to put it on the balloon yourself?
No.
Manually, or is?
No, it's just a normal pre-mounted 1-layer stent, cover stent.
So we don't know.
I think you can see.
I don't know this one.
I
so.
think you can see outside.
Yeah, we can see
There's
outside.
something
So,
outside.
okay, because the one we have in my center is a double layer, as impossible to put it on 5 French. Sometimes also impossible to put in some distal lesion or a complex lesion.
Okay, I have to stop this discussion because for the sake of time we have to go on. Thank you, Doug.